And we're going to move on now to our last speaker in this session, and that is Dr. Anne Hollows, who was previously Principal Lecturer in Social Work at Sheffield Hallam University. So Anne, warm welcome.
Thank you, Alan. And thank you for all the other contributions, which have been fascinating. I've been butchering my script as I listen to what everybody else has said. I'm speaking as somebody who's been involved in social work since 1972, quite a long time, but also as someone who has been a home-based carer for my late husband, who developed Parkinson's disease and ultimately spent the last 10 years of his life in care. And for my mother, who died recently, he was 96 and had dementia. So I have had a range of those experiences, though I must say my professional involvement has been more with children and families, but there are things we can learn from that too. I want to start with taking you back to about 1978 when I was a hospital social worker in Scotland. And this showed really clearly to me how health and social care were interdependent, but not the same thing at all. When we wanted to discharge someone from hospital, we used to have a week's notice and we would assemble a team of OTs, physios, a social worker and possibly a community nurse or health visitor, and we'd take the elderly person home to assess exactly how well they could manage and what was needed to enable them to have a successful discharge from home and an independent life. My neighbour in Sheffield runs the part of the home care service for Sheffield, and she tells me that now she gets a phone call that someone is being discharged tomorrow, and this is the broad picture, and can she put in services? The result is usually disastrous. And very quickly, that person who is so long to get back to their own house goes back to hospital because they fall or something else fails. And I think it's this interdependence of professionals that is actually crucial to making social care work. Apart from that, of course, there are all the issues about the way in which social care is organised, which all comes down to funding, that normally the service is only for 6 weeks and it's delivered by a whole variety of care workers attending at a variety of times. So you find that maybe a care worker will be arriving at 5 in the evening to put someone to bed when they haven't had their tea. And some people those who can end up resorting to paying for care themselves. Other people manage, as both Alan and Sue have pointed out, with very inefficient or no care at all. When my late husband was in hospital, there was a point where the senior registrar in neurology looked at me and said, "You're a professional person, you're an academic. They're going to want you to give up work to look after him. Don't let them. Don't let them, because you can't do it." And that she argued my case and I argued my case. And eventually he went to a very good nursing and care home. Now, that led to another issue. How do you pay? This was a man, a retired academic, who had developed Parkinson's disease and a psychotic condition that was very serious. And we were able, because I knew what this was all about, because I was a social work academic, to argue for continuing healthcare funding. Somewhere in there, in the small print, it said that there might be a review at some stage. He spent 10 years of his life in that nursing home, and the weekly cost was somewhere between £1,500 and £2,000 a week. That's the ballpark that we're talking about. After several years, the first review took place. I was absolutely terrified. I didn't sleep for weeks, waiting to find out how it would work. We were lucky. I knew how to play my answers. I helped the staff play their answers to make sure that he had sufficient severe categories to get the funding. But not everybody else was successful. And what happened to some people was that they found that the care they'd received in this care home had actually ameliorated their condition so that they didn't need funding anymore. So they'd have to leave. Now, that sort of thing coming from the bureaucracy that is health and social care is neither healthy nor is it social care. I want to move on to look a little bit more at what some of the points that have been picked up already. Certainly, there's lots of advantages of technology, but thinking about my very elderly mother, technology is only as good as the person who can use them, and she couldn't. The basic press button thing was her lifeline. She could manage that, even if she did go on to believe that the man from the Lifeline service was camped throughout January in her back garden so he could come every time she pressed the button. And I think that the other thing that we've learned is that isolation in the pandemic has been of particular difficulty for many elderly people. What they wanted was real life people. They wanted the warmth of human contact. And I was rather alarmed to read that in a German study, they were looking at the potential of occupational activities being delivered in the form of bingo with Alexa. And that was not something that I felt we could promote. On the contrary, there are some advantages of increasing automation that are apparently going to reduce employment opportunities for people. We've heard much about the one-way traffic between care home workers and the much better paid jobs in supermarkets stacking shelves. Maybe there's a possibility that the computer systems can stack the supermarket shelves and the traffic can go back in the other direction. Care deals with vulnerability and increasing dependence and recognizing the person beyond the frailty. And I just want to spend the last few minutes of my talk looking at some of the ways in which effective social work practice can respond to this. And this is based on some research and development materials that have come from Bristol University. The first point that social work can make is in understanding relationships and using a very poignant case of a couple with different kinds of deterioration of health and mental status. The social worker in one of the vignettes responded in this way. She said, "I think I see them as being devoted to each other." And then she said, "But not all couples are devoted to each other." But if you've got a case like this where they're so devoted to each other, I think that has its own specific problems because of their reliance on each other. And how do we factor in those points as we plan social care? Equally, plan care for people who are not devoted to each other. Another social worker said that we need to think what we might want for ourselves. I think I would like, if I was in that position, that the social worker demeanour, I would like warmth, communication. I would like to know that she understood. Her voice, her body, her attitude. And I wouldn't want her to come with a message of changing things at that point. I'd want the relief that someone understood, but I wouldn't want the thought of drastic change, of moving out, or the life that I've been used to changing too much, because I still want my previous life. Social workers also can help people to deal with the hardest question. The social worker has the skills both to pick up on the cues and the clues that it is time to talk about end-of-life care arrangements and to create the right environment for open, sensitive discussions with the person and, where appropriate, with the family. So the service options that might enable us to move forward. Drawing on some of the work that I've done at Sheffield Hallam in relation to children's services, all professionals must have shared understandings of roles and responsibilities and communication, and they can be co-located. There are, in some parts of the country, community matron systems where a group of professionals work together and support people in the community and in care homes. There needs also to be strong management support for collaborative working, and certainly in children's services we found that whereas the frontline professionals were happy to work together, the managers one level up were not so keen. And finally, to a couple of points from learning from my work in Europe. In Spain, I've seen residential care often located on the main street, where people can come and go from the care home and can sit on the wide balconies watching the frequent fiestas. In France, in a couple of small towns, I've seen small care homes located on the marketplace. In Holland, there's a coffee shop, not that kind of a coffee shop, in the home to which relatives, friends and communities often go. The home with its coffee shop is located on the main street there too. And in Denmark and the Baltic states, social pedagogy has formed the basis of training at every level. And finally, from my varied professional and personal experience, I cannot avoid adding that this should never be an income generating activity. It is a public good, and we should be looking to some of the developments in small cities like Preston, where cooperatives for community care and residential care are combining the interests of the residents, the elderly people, their families, and the people who work with them. And that seems to me to offer a very creative way forward to the future. Thank you.